Welcome to More Than Miles, where we use storytelling and expert interviews to empower endurance athletes and healthcare providers. I'm Dr. Kate Mihivik-Edwards, physical therapist, author, educator, entrepreneur, and former endurance athlete.
And I'm Dr. Kacy Saunders, physical therapist, runner, and triathlete, and together we're your co-hosts. Our goal is to always keep our athletes healthy on and off the road, because we know that our athletes are so much more than their body and their sport. We're glad you're on this journey with us. Now let's get to the show.
Today, we're really excited to have Dr. Jonathan Kim on our show. Dr. Jonathan Kim is an assistant professor of medicine in the Division of Cardiology at Emory University, and additionally holds an adjunct assistant professorship in the Division of Applied Physiology at the Georgia Institute of Technology. Dr. Kim received his Bachelor of Science in Biology at Emory in 1998. He was awarded a Fulbright scholarship and studied in Melbourne, Australia, before attending Vanderbilt University School of Medicine. Dr. Jonathan Kim is a sports cardiologist and researcher in Atlanta, Georgia, and he's also my sports cardiologist. He is the director of sports cardiology program at Emory Sports Medicine Center, the medical director for the Peachtree Road Race, and works with several professional sports teams, including the Atlanta Track Club. He and I have worked together for several years, educating endurance athletes on cardiac health. Thank you so much for joining us, Dr. Kim.
Thank you for having me, as always.
That is a mouthful. You have done so much.
I appreciate it. Thank you.
You're welcome. Well, we wanted to have you on the show today because of all the years we've worked together and all of the things that both Kacy and I have learned from you. We really want to bring that to our audience so that they can really get a glimpse into what sports cardiology is. And we want to talk a lot about that and how it impacts endurance athletes, why endurance athletes should know about it, and then also talk a little bit about the stuff that you've been doing recently in terms of your research on COVID.
Let's start by talking about the difference between cardiology and sports cardiology. So what sets sports cardiology apart?
Yeah, that's a great question because sports cardiology is a relatively new field. When I say new, we're talking 10, 15 years or so where it's really gained prominence. And much like many other niches within medicine, certainly specialties, things get even more specialized. And we recognize that athletes, athletic individuals really have different priorities, certainly mindset, as well as how different diagnoses impact this population are really different compared to the general population. And so this field of sports cardiology is really geared towards addressing the cardiovascular needs for athletes or highly active individuals. And so this ranges from competitive athletes, of course, but really more so your highly active recreational individual. So these would be the majority of patients that you see in your practice, certainly the members of the Atlanta Track Club, and across the United States and worldwide, the millions of individuals that are participating in recreational endurance events. And that's how this field has really evolved. And I think as more and more athletes hear about this, they recognize that, hey, I have this cardiac risk factor. I've been diagnosed with this cardiovascular condition. I'm not feeling like perhaps my cardiologist right now gets the fact that exercise is a big part of how my management will proceed and has to be incorporated or at least addressed. If I have to back down on exercise, give me a reason why. If I have to back down on activities, how much can I do? And that's where the field of sports cardiology has really come into play, dealing with those specific questions, but also many of the conditions that we see regularly in athletes.
And I know from my personal experience, I felt like you were somebody I really wanted to talk to because no one really understood me and understood what I was going through, not necessarily from a cardiac position, but also from a cardiac position and an athlete position.
Absolutely. And not only just recognizing how that's important and how that's really the mind of the athlete is a big part of the athlete, and ignoring that, the athlete probably doesn't feel like they're getting the type of attention that they are really looking for. But also picking up conditions in athletes can be tricky. And many times I'll see athletes that have symptoms that perhaps aren't as aggressively worked up as they should have been, or perhaps testing. Again, many people in the cardiology clinic are folks that haven't been as active. Obviously, inactivity is a big cardiac risk factor. And so patients who have heart attacks may be patients that have previously been very docile. So many of the tests, how we exercise patients in the cardiology clinic, are geared towards patients who aren't typically running 4-hour marathons, or certainly much faster marathons, Boston qualifiers, et cetera. And many of the tests that are performed in the cardiology clinic just don't really aren't set up to pick these conditions up as well. So many times I have to redo many of the workups because somebody came in who is a high-end runner and they feel like they have exercise intolerance. The cardiologist says, so are you having chest pains? Are you having shortness of breath? And they're saying, well, I'm used to running a 3:10 marathon. That's my usual time. And now I can't break 3:30. Something is off. And the cardiologist laughs at them like, come on, you're running marathons. Well, in actuality, some of these athletic patients truly have underlying conditions. They just have such a strong baseline. So kind of picking all these clues up, I think, really should be at the direction of somebody who's used to taking care of these type patients.
God, that's what we deal with all the time, isn't it?
All the time. Yeah, the specificity is huge in this area of medicine for sure.
Yeah, and I'll just add, certainly many times I will see patients who have quote unquote exercise intolerance, and it is overtraining or deconditioning. Unfortunately, we all get slower as we get older. It's just an unfortunate part of life. So I'm not trying to say everybody out there who feels like they have exercise intolerance all of a sudden needs to panic and come see me because they've got some terrible cardiac condition. My point is that many times athletes know their body so well, and it's important not to ignore these factors. And sometimes these very subtle changes can be indicative of something more concerning. Sometimes athletes will ignore very overt cardiac symptoms.
I don't know what you're talking about.
I'm not going to say anything more than that, Kacy, but many times it's just that mind of the athlete again. And as an example, somebody who continues to have chest pain when they're running, hey, I'm warming up and I feel like there's an elephant sitting on my chest. But, after the first couple of months, I feel fine. Well, that's actually something that is classically described as warm-up angina. And it's actually a real phenomenon that is very concerning for underlying blockages in those coronary arteries. And I've certainly seen my fair share of masters athletes who come in with that and think, oh, my buddy who saw you forced me to come in. I think this is nothing. And I'm actually like, this could be something. So it is important for athletes to recognize that just because you run 40 to 50 miles a week doesn't mean that you can't have a potential underlying cardiac concern.
What are those red flags? Like, what are things that you really think are worth seeking out a sports cardiologist for?
That I think is a really important point. And I love doing these because I think it's a nice way to really reach out to many individuals who generally are very healthy and probably don't hear this message repetitively. Most importantly, it's issues, symptoms that come about during exertion. And so that link between physical activity and a cardiac symptom. And these symptoms can be numerous and may seem obvious, but include chest tightness, chest pain. And it's not even a sharp pain so much as a pressure in the chest, feeling like, as I just mentioned, somebody pushing on your chest or sitting on your chest. That is very consistent with angina. Excessive new shortness of breath, or that sensation of exercise intolerance, meaning you're just feeling way more winded at a certain level of exertion that several months ago or a year ago you used to tolerate just fine. Obviously, getting lightheaded, passing out during exertion, feeling your heart race inappropriately or your heart fluttering in your chest during exercise, anything that feels off during exercise is clearly a sign that should be checked out. Now, if you're having other symptoms that aren't during exertion, that doesn't mean that they need to be blown off. It's important probably to raise attention to that with your doctor or come seeing a cardiologist, sports cardiologist. But those exertional symptoms are clearly the red flag. And exercise intolerance is a very nebulous description. You're not going to wake up tomorrow and have exercise intolerance. We all have our bad days running. For some reason, for me, the last couple weeks it's just been brutal. Hopefully with this nice weather out now, maybe I'll feel better. But it's usually that, hey, you know what? When I really reflect back over the last 3 to 4 to 6 months, there's a big change. And, so it's not just that one-off. It's this repetitive kind of change in how you're feeling in your performance that's clearly noticeable and not something that, the athlete can ignore anymore, or it's not clear to them that something is off. And I find that sometimes because athletes are so well conditioned that they don't come in with the classic chest pains or chest tightness. Sometimes it really is exercise intolerance. that can be the symptom. So it's a very non-specific entity. And again, many times it can be something very benign, probably more often than not. So again, to reassure everybody out there that more often than not, it probably is a more benign answer, but sometimes it isn't.
I know that I send a lot of people your way, and most of the time it's nothing. But
I don't know, you've been pretty good. I have to say, you've got a nice, keen sense. You definitely have sent me some folks where we picked important diagnoses up.
Well, that's true. But I think it's also personal experience. Many of the things that you've described, I had. So a lot of exercise intolerance when I thought that maybe I was overtraining and told myself I was overtraining, but it was really something I was ignoring for a long period of time. And I would have to stop in the middle of runs to catch my breath. And now I know that's because I was in an arrhythmia. Sometimes it was, my sports bra felt really tight around my chest when I was running. And again, that's because my heart was beating too fast or passing out that I ignored, which I've kind of told my story already on this podcast. There are scarier things, but then some of those little things, like I was more fatigued all the time after exercise. I had to go to bed earlier. And those type of things really came up for me. So when you were talking about that, I can absolutely relate.
Yeah, no, absolutely. I think you definitely have for obvious reasons, a very strong understanding of some of these constellation of issues to watch for.
I think you do too, Kacy. I mean, you've heard Dr. Kim speak so many times.
Yeah, that's true.
and we talk about it
of listening many times.
And we probably talk about it ad nauseum in terms of, what we need to look at in the clinic and the type of questions we need to ask our clients so that we don't miss anything.
Maybe we can go over some of those questions. Like, what do you feel like for us as physical therapists are important questions for us to ask to screen some of these, seemingly benign things out?
Yeah, no, I think we talked about some of them for sure. And I think that's exactly what you have picked up with some of the referrals. You're just talking to a patient. They obviously are coming to see you with a primary musculoskeletal concern. They're being worked on. And then somehow or another, they start talking about how they're so much slower, they're feeling more winded, and looking for those exertional type cardiovascular type symptoms. And I think that is clearly then the right move, which is what you guys have done. And I think, the reality is when you think about recreational athletes, the majority of these individuals aren't talking about this when they're actually seeing their regular doctor. And so from the physical therapist standpoint, because there's such a high volume of recreational athletes that roll through you, it is important to pass this message on to colleagues, trainees who are becoming therapists, because it is a window into catching athletes who may not necessarily pass this on to their doctor, who may actually have a reason to be seen by a sports cardiologist.
Yeah, I think so. And one of the things that you've said in several of the talks that I've heard you do is family history being really important. Could you talk about that a little bit?
Yeah, so family history, many of the conditions that, and really even things like coronary artery disease, but some of the other inherited heart conditions are just that, they're genetically inherited. And so it is important for athletes when I see them to kind of roll through a history of individuals, blood relatives, first degree relatives, who had an unexplained death. Clearly, if they know it was a sudden cardiac death before the age of 50, that's an important clue. And even some of these conditions. So, we have a laundry list of questions that we roll through, and we always go through these whenever I see athletes, particularly young athletes who are going through pre-participation exams. And it's always funny because these are conditions that nobody's ever heard of in general. And so there's always a chuckle when I say hypertrophic cardiomyopathy, and they're like, I never heard of that, doc. So I try to also include simplify things, if you will. So sometimes I'll say hypertrophic cardiomyopathy, but then I'll follow it up with somebody in your family that has a condition where they were told their heart is too thick, because sometimes that's how they hear about it. Sometimes that's how the family member actually understands their diagnosis. Another one is a young family member who had a defibrillator placed in, or has anybody had a defibrillator or a pacemaker put in when they were young? So not focusing on whenever, obviously as we get older, that's not uncommon to have pacemakers or defibrillators even. But if you're younger than 50, that's certainly a red flag. Or other kind of weird circumstances in a family, drownings, single vehicle car accidents, somebody hit a tree and they died. I'll take the time to go through that, because when an athlete comes in with a symptom, sometimes you may find certain things in the family history. And all the questions that we ask, besides kind of going through descriptives of symptoms, a positive family history of something like that definitely really ups the ante as it relates to potentially actually something being present versus not.
Yeah, that's one of the
I would
things
say for colleagues, for other therapists who are listening to this, want to be careful as well. I don't think any physical therapist should feel the pressure of kind of going through this detailed family history. But, maybe sometimes somebody will say that, that'll come out like, oh yeah, my so-and-so died when they were 25 or something. And that may be a reason to be like, hey, has anybody ever actually kind of screened you or other family members? And if they say no, then it's a direction to at least starting off with their primary care doctor to kind of get that very detailed history. Family histories are very important.
Yeah, I definitely agree with that. And that's kind of what I do. I'll do the blanket question. Has anyone ever died in your family young or had anything like that happen? And then pairing that with some of the symptoms that they've given me, I send directly to you and you decide whether or not they actually need further testing, which has been really great.
Yeah, and I think this is a good segue because I think eventually COVID is going to be a familial history issue down the line. So we're going to pivot a little bit, talk a little bit about that. So I have a few friends who've had COVID and they were asking me, when can I go back to running? What can I do? Like, how do I get back into my regular physical activity? And I said, I don't know, let me look it up. So I Googled and I found an article by you and I was like, oh, I know that guy. So thank you for doing research in this space because I feel like it's going to become really, really important here in the future. Can you talk a little bit about that paper that you wrote about cardiac screening and when it's appropriate post-COVID?
Yeah, absolutely. And for sure, we're to that stage of COVID now to where recreational athletes, and this is a good thing, which is the fact that clearly with vaccinations, the light at the end of the tunnel is there for racing. There's no doubt about it. It's not going to happen next month or the month after, but as the months progress, probably even later into 2021, people are going to be back training again. I know some endurance events have been conducted, but certainly not to the level that we're all used to. And so having recreational athletes who have had COVID in the past or who may unfortunately get it before they get vaccinated is an issue. And so one of the reasons why I thought this podcast was really important was this messaging for COVID, because there's a few important messages. Number one, those consensus recommendations that you read. So we wrote that as a part of the American College of Cardiology, really focusing first the competitive athlete, because that's what we were thinking about last summer. And then as we wrote the follow-up paper in the fall, we did start addressing masters athletes. And the one thing that we really emphasized up front was that the majority of athletes, because recreational masters athletes are generally healthier, even the older ones, and that's a positive, right? We know that lack of comorbidities, your risk of having bad COVID outcomes is decreased. We know that. So the majority of recreational endurance athletes who have COVID are going to be fine and are going to be okay. And therefore, I think the right message is not for people who listen to this or for recreational athletes to think that, oh my God, I had COVID before I start training for a marathon. I got to go see Dr. Kim or a cardiologist. I got to get all these tests that I've read about. The majority of individuals probably don't. In fact, we even kind of lessened our conservative recommendations a little bit and felt that mild COVID symptoms really don't need screening. It's once you start getting to more concerning symptoms, chest tightness, shortness of breath, fevers, chills that have lasted more than a couple of days. So these are the more significant, moderate symptoms of COVID. And even for those, if you're a recreational athlete, the cue there may be more just, hey, maybe I should just reach out to my doctor, because there's a lot of recreational endurance athletes out there, and we don't need everybody who runs to start seeing their cardiologist and inundate the healthcare system to get testing. And that's important. Again, the data will continue to allow precision about who needs screening. But right now, I think the message is you probably don't need to be screened. If you have a cardiac history, for sure, you're going to reach out to your cardiologist. If you're a marathon runner, see your sports cardiologist and make that determination about what needs to be done. So then the second message is then, if you've had COVID, what to do. And I think that message is, number one, you got to comply with self-isolation, clearly. Endurance athletes have a really bad habit of running through illness. And that's why this is an important message.
Yes.
You have the flu, I have a fever to 101. You know what? Let me just go out and run in the cold weather because that's going to make me feel better. COVID requires more respect than any respiratory viral illness that we know of right now, because it's still novel and it does some bad things to the heart. We see that in sicker patients with COVID. So this is the time that the message really needs to be passed on, that when you have it, even if you have mild symptoms, give it that 10 days, take 10 days off. I feel pretty strongly about that right now because there's still a lot we don't know. And if there is underlying inflammation that is within the heart, but due to COVID, exercise can make that inflammation worse. And now this actually becomes a risk factor of something bad happening to you. So allow yourself to recover. Don't do anything. And once those 10 days are up, if you've gotten better, all your symptoms are gone, maybe with the one caveat of loss of taste or smell, because I think we've all seen that that's the one symptom that can really lag really for a few weeks. That's the one thing that is probably okay to start, once you've done your 10 days, if that's the only thing that's left over and you're feeling better, to slowly build your exercise up. So you've taken 10 days off, you're going to be a little deconditioned anyway, but to slowly and gradually escalate that training. Make it really deliberate. This shouldn't be hey, I'll just do one day of 50% and I'm good. Next day I'm back to 100%. Give it, and again, I can't.
Sounds like some people we know.
I know it does.
And I can't give specific, like, this is the graded approach, because there's no evidence to support that. And so anything I would say would just be an opinion. I kind of leave it more qualitative. If you were asymptomatic throughout, you can probably push it a little bit more. You don't need to take 7 days because you had no symptoms. If you had more clear symptoms of COVID, it may take up to a week. But the point is that you want to have that graded approach to make sure you aren't noticing any chest tightness, any shortness of breath, any true exercise intolerance or cardiac symptom that would then clearly warrant a red flag to be checked out. And so that, I think, is the important message for most recreational athletes, is that you can probably do this all on your own. You don't need to go see the cardiologist. Again, remember those two messages. Respect the self-isolation, respect the virus, allow yourself to get better. Don't get back at it right away. I can tell you some of the patients that I've seen, recreational athletes that I've seen over the last couple of months that just come seek me out, that are recreational endurance type athletes who are still having symptoms, that is kind of an ongoing theme, is that they just treated it like any other cold they had, and they started exercising when they probably shouldn't have. And I'm not saying that's why they still had persistent symptoms, but I still give that message to them about pass this on to your friends, because you probably have a ton of other endurance athletic friends. This is the massive message that we want to get out there. And it's just important, I think, to continue to respect this virus and have that as the message, rather than I need to go get screened just because I had COVID.
So it's interesting, because what I would like to say out loud again, if you have a cough still, if you are still fatigued, and you think I'm better from COVID, perhaps you should wait a little bit longer. Is that what I'm hearing, until those symptoms clear up?
Yeah, exactly. Anything that lasts beyond 10 days, that's a reason just to see your doctor anyway. I think that's the message, whether you're an athlete or not. If you just have ongoing COVID symptoms that just haven't gotten better, whether it's long haul or just whether there's been something that's happened to the lungs, you want to get checked out. I do think from a message standpoint to athletic individuals, symptoms more than 10 days are ones to where not only should you still lay off the exercise, but at least starting off with a visit with your primary care doc, just to see, again, because COVID is more than just the heart, of course, to get checked out. And for those that fall into the majority category, which is you get better within 10 days, that's slow progression. And then just take your time, you're in no rush, and just ensure that you get back to baseline conditioning.
Do you guys have some kind of, you said you don't have a lot because it's new and all this, but you don't have a specific return to run program, or do you have some kind of framework in your head?
Yeah, I don't have a specific algorithm, and I've intentionally done that and there are actually some papers out there that I've put forth, because I think a lot of it is totally made up. And sometimes I think if you're doing this at home, other individuals can take charge of that and can qualitatively manage that on their own. If you happen to be very elite and you have your own coach trainer, well, now you have somebody that can really kind of help guide that and come up with heart rate thresholds, et cetera, and percentages that they can work, because everybody's different. I think a lot of it as well is based on, if you're a lineman who is not engaged in any sorts of aerobic exercise based on the position, being a football lineman, well, the return to full training is going to be a little bit different than an elite basketball player compared to an elite cross-country runner, all based on what your baseline VO2 is, what your training is like. So everybody's going to be a little bit different.
Yeah, I completely agree.
Yeah, I did see a paper that had an algorithm of sorts. It talked about target heart rate and symptoms, and it was really well done. It was pretty clear, but I think what's really important here is that you listen to your body and how you are feeling, not just following the plan to follow the plan. really monitoring for those symptoms that you were talking about, shortness of breath, fatigue, intolerance to exercise, and not just letting the process happen organically.
That's really hard for endurance athletes because we're used to following a plan. We have, 12-week, 16-week, 24-week, sometimes longer if you're a triathlete, schedules that we follow, and we do exactly what the schedule says. And if you have a cold, like you mentioned before, you're like, well, my schedule says run 10 miles. Should I really take it off because I have a cold? It's just a cold.
And in general, that used to be the going thing, was like symptoms above are ones you probably can ignore. When you feel symptoms below, like the deep respiratory stuff, that's when you really, that pre-COVID, that was this generalized advice that a lot of people utilize. And COVID, I think, has changed that for sure. I mean, I don't think that everything above is a green light that, hey, while I still have it, I can just hit my treadmill. I'm in self-isolation. It is definitely not the way to go about things. It is tough. I mean, I'll tell you, I had my own COVID scare, which I'm convinced I had a false positive COVID test last summer. I had to get screened before I did physicals for the Falcons. And I firmly believe it was a false positive because I had multiple tests, including the day after, that was negative. It just didn't make any sense. Nobody around me ever got sick. I never got symptoms. I checked antibodies 6 weeks later, negative. And for whatever reason, you can have a false positive test. But I hunkered down in my basement. I could have clearly run on the treadmill because I never had a symptom, and I stayed away for 10 days. So if I can do it,
wow.
If I can preach to the quiet, if I can preach it and I lived it, you can do it.
That's right. I'm really impressed, actually.
I'm very impressed. That's what I wanted to say as well. That is impressive. Treadmill and all. Wow.
The one thing I would say too, though, which is important, is this long haul. I have seen long haul in a few patients, both young and older. And so it is another sign, though, that if symptoms really are persistent, you need to get checked out. And when I say long haul, these are patients, athletes I've seen that the testing has clearly shown there's no myocarditis. The heart is fine. And they never had COVID pneumonia per se. And they just continue to have these weird non-specific symptoms or fatigue, they're short of breath. So you got to be mindful of that. And that is, I think, just an important reason as well, that we all got to hang in there a little bit longer. And I think sports can continue on while COVID is not eradicated. But it's a terrible illness. It's a terrible disease. And most people who are healthy and young and active can get it and be totally fine. But some people really struggle. And whether you are an elite athlete or not, it can happen for sure, this long haul phenomenon.
Yeah, absolutely. Well, thank you, Dr. Kim. Is there anything else you want to ask while we have him here before we let him go?
Yeah, I have. A lot of things I want to ask, but I think that this has been great. It's going to be a great resource because we wanted to ask about if there's any resources out there. And I kind of alluded to that there's not. And I think actually our podcast is going to be one of the first of its kind to provide some sort of resource for athletes who are wanting to get back in a healthy and safe manner.
Yeah.
Yeah. And even some of these consensus recommendations we wrote, we talk a little bit about, that's obviously, the medical community, those that are really interested can find this, but the general public isn't reading JAMA Cardiology on a regular basis. And so doing these spots, and my colleagues are doing them in their own communities, I think that's really the best way to spread the message, because it's easy to spread the message to your elite competitive athletes because they're there and they're sanctioned athletes at universities or professional athletes. But for everybody else, they don't really know. I'm certainly not tired of saying this message because I think it's got to be repetitive to kind of get everybody out there to be aware, again, to know when to seek help if you've had COVID. And if you have COVID, some good kind of rules of thumb while you're infected about hopefully getting back out there and getting to run and bike and swim and all these things that you want to do unscathed.
Yeah, no, I completely agree. And we'll put in our show notes some of the papers that you wrote and have worked through so that people have those in case they want to read them. Again, like you said, most people, unless they're nerdy like us, probably won't read them, but that's okay. We'll put them anyway. Are there other ways that our audience can connect with you if they want to?
Yeah, no, for sure. In terms of seeking me, it's pretty easy. I'm easy to look up in terms of consultations, et cetera. And we always try to make it a priority to, obviously, we're used to take care of athletes, that we like to get athletes in quick. And we certainly like to kind of ensure that we do what we need to do to hopefully get people back out doing their, getting back to their exercise regimens as soon as possible.
That's great. And are you doing, just in case people are hearing this that aren't in the Atlanta area, are you doing any online or virtual visits anymore, or are they all in person?
Yeah, no, I'm still doing virtual. I did a couple this morning. Actually did one with a patient up in Virginia. So we're still doing them. And then the other thing in terms of just random things here or there is there's always social media. So I have a Twitter handle, very easy to kind of look up, find me. And I haven't been as active over the last couple of weeks, but there's always stuff as it relates to COVID and athletes that we'll post.
What is your Twitter handle?
Oh, it's at Jonathan Kim MD.
That's great. Well, thank you so much. I really appreciate you coming on always. And again, I've learned more today.
I've learned a lot. I can't wait to pass it on to people I know who need it.
Absolutely, guys. I really appreciate the invite and always happy to do it again.
Well, thank you.
Yeah, thanks, Dr. Kim.
Thank you so much for hanging out with us. We hope that you enjoyed today's conversation. As you can tell, we absolutely love spreading knowledge about endurance athlete health.
Be sure to subscribe and rate the show on Apple Podcasts, Spotify, or whatever platform you happen to be listening in from. It really helps us get the word out about our show so that we can reach more awesome people like you. Be sure to share the show with your friends, running buddies, training partner, family, dog, scream it from the rooftops, whatever works for you. See you soon.